Here's a detailed case study involving a complex vascular surgery case and the surgical techniques employed. Case study: complex aortic aneurysm repair. Patient A, a 65-year-old male with a history of hypertension and smoking, presented with severe abdominal pain and hypotension. Diagnostic imaging revealed a large abdominal aortic aneurysm with signs of impending rupture. Due to the complexity of the aneurysm, involving extensive involvement of the visceral segment of the aorta, surgical intervention was deemed necessary to prevent catastrophic rupture. Detailed preoperative assessment included a comprehensive evaluation of the patient's medical history, physical examination, laboratory investigations, and imaging studies. Multi-detector computed tomography angiography provided crucial information about the anatomy of the aneurysm, including its size, location, extent, and involvement of branch vessels. A multidisciplinary team comprising vascular surgeons collaborated to develop a surgical plan tailored to the patient's anatomy and comorbidities. The goal was to perform a durable repair while minimizing perioperative risks and preserving visceral perfusion. Given the complexity of the aneurysm, an open surgical approach was chosen over an endovascular technique. A midline abdominal incision was made to access the aorta and its branch vessels. The aorta was clamped proximally and distally to the aneurysm to achieve proximal and distal control. During the clamping period, meticulous attention was paid to maintaining visceral perfusion through collateral vessels, including the use of temporary shunts if necessary. The aneurysm sac was carefully dissected, and thrombus within the aneurysm was evacuated. The diseased segment of the aorta was resected, ensuring complete excision of the aneurysmal tissue. A polytetrafluoroethylene graft was then interposed to reconstruct the aorta, providing a durable conduit for blood flow. Special attention was given to preserving blood flow to vital visceral organs, including the kidneys, liver, and intestines. Branch vessels originating from the aneurysm were re-implanted into the graft using meticulous microsurgical techniques or managed with adjunctive procedures such as renal artery bypass grafting or visceral patch angioplasty. Hemostasis was achieved meticulously to minimize postoperative bleeding and hematoma formation. The abdominal incision was closed in layers, paying careful attention to minimize the risk of wound complications such as dehiscence or infection. Following surgery, patient A was closely monitored in the intensive care unit, ICU, for hemodynamic stability, renal function, and signs of visceral ischemia. Postoperative imaging studies, including duplex ultrasound or CT angiography, were performed to assess graft patency and detect any early complications such as graft thrombosis or endoleaks. Patient A had an uneventful postoperative course and was discharged home with close follow-up. Follow-up imaging studies demonstrated excellent graft patency and exclusion of the aneurysm without evidence of endoleak. Long-term surveillance was planned to monitor for graft-related complications and ensure ongoing vascular health. This case illustrates the complexity of managing patients with extensive aortic aneurysms and the importance of a multidisciplinary approach to surgical planning and execution. By employing meticulous surgical techniques and perioperative care, vascular surgeons can achieve durable repairs while minimizing perioperative risks and optimizing patient outcomes. Give us a call at 480-668-5000.